Hello. So it's Ed Ryan again, and now we're going to do some deeper dives into some cases of global infectious disease etiologies, so we can put some of the info we just learned into practice. We have 5 cases. We'll see if we can get through them all. So I have no conflict of interest, and if I point anything out off label, I will point that out. So case one is a 50-year-old woman who was brought to the Mass General emergency room from Logan Airport. That's our airport on the other side of the tunnel. She was on her way out of Boston, and in the airport, she became disoriented and aphasic. So her friend got medical help, and 911 came, and they brought her over to the emergency room. In the emergency room, she was afebrile. She was disoriented and aphasic, but her physical exam was very unremarkable. So they thought maybe she had had a stroke, an embolic stroke or something. And so they did some imaging, but it was unrevealing. Neurology saw her in the emergency room. They didn't think it was a stroke. They thought it might have been some bizarre seizure or maybe some infection that they didn't know. So they started her on a broad range of things. And then her labs started coming back, and she was very hyponatremic, 124. She was in acute renal failure with a creatinine of about 4. She had a transaminitis, Billy's of 4 and 7. She was anemic, a thrombocytopenic with a platelet count of 34. And a bandemia. So they took a step back, and remember, this is neurology seeing her. They said, well, she has altered mental status, renal failure, hepatitis, and thrombocytopenia. And granted, she was afebrile, but they thought perhaps this was TTP, or thrombocytopenic thrombotic thrombocytopenic purpura, although fever with that. So they consulted hematology, and hematology did a peripheral smear in the emergency room. And here's a microscope analysis of that, and I think you can see on some of the red blood cells some blue things inside of them. And here's some more up close of those. And on the right hand side, it's a little out of focus, but you clearly see red blood cells with blue and sort of goldy things inside. And so appropriately, the hematologist looked and said, "Oh, this looks like malaria." Now, some background was she had been visiting Boston for 3 days for business. She traveled a lot for business. She had just come from India, and right before that, Nigeria, all within the last 3 or 4 weeks. So we come back to that when we talk about that previous thing about what often presents within 1 to 3 months of international exposures. She took no malaria chemoprophylaxis, and her friend reports that she was feeling ill for the last couple of days with pounding headaches, but there was no obvious fever, etc. So it was estimated the parasitemia level was 7%, and ID was consulted in the emergency room, and a rapid Binax test was performed, and it was positive for falciparum. So at this point, artesunate was not yet in our formulary, so we requested it from the CDC, and an NG tube was placed because of her mental status, and oral artemether lumefantrine was administered down the tube. So that's an artemisinin and combination therapy treatment, an ACT. We'll come to that in a second. And she was admitted to the MICU for further care. She required intubation. She required pressor support. She required CVVH. She was very, very sick. So she had difficulties oxygenating, although her chest X-ray looked good, suggesting perhaps microvascular disease. She was an ATN with ischemic issues of her kidneys, and unfortunately, she was having severe vasospasm issues, and with her severe illness. And eventually some of these extremities didn't do particularly well. So clinical decisions, which type of malaria? Do you classify this as severe or uncomplicated? And which species are you dealing with? And we less look now at resistance, and I'll tell you why. The classic used to be, oh, which species is it? And was it from a chloroquine resistant or sensitive part of the world? We've sort of moved away from that paradigm. The CDC really hasn't yet. But it'll be interesting to see over the next 3 to 5 years. But the WHO has clearly moved away from that paradigm, and it's actually gotten a lot simpler. So let me take you through it. So if you remember malaria, there's resistance patterns of all different in different places of the world, and depending on the species. And if you know exactly what you're dealing with and you have other options, you can do that. But I'm really going to simplify it for you. If you have falciparum malaria, and the person is uncomplicated, give them an ACT, an artemisinin combination therapy. In the United States, there's only one agent that's called Coartem. Is its trade name? It's artemether lumefantrine. It's an oral agent. You should have it on your hospital formulary. Please, 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 if you do nothing else after this lecture, just get these 2 agents on your hospital formulary, because these are the standard of care now. All right, so oral, uncomplicated, you give them oral pills, and if it's complicated, we'll come to that in a second, give them IV artesunate. End of discussion, right? You don't have to think about all these other agents are second or third or fourth line agents, etc. If you don't know which species the person has, you treat them this way. If you're 100% sure it's a Vivax or Ovale, and if it's not from a resistant part of the world, you could use other agents, but don't. All right, just make it simple. ACT or artemisinin or artemisinin. All right, and if you notice, here's a big study that showed mortality difference with artemisinin-based therapy. Right, so you save lives by giving artemisinin. This is out of Africa, and here you see the same mortality difference in Asia. So there's really no reason to use inferior agents. Get these agents on your formulary. And the WHO every year comes out with their recommendations for guidelines, et cetera. And here's the most recent one from 2023. I'll make it simple. Look in the upper left-hand corner. This is treating artemisinin. This is treating uncomplicated malaria. And what does it say? High certainty evidence, ACT. Now, there's a couple of ACTs available in different places in the world. In the United States, the first one is available, artemether lumefantrine. How about non-immune travelers down the bottom? High certainty evidence, ACT. How about severe malaria in the upper right-hand corner? High certainty evidence, IV artesunate or intramuscular artesunate. All right, so it's really simple now. Get those two agents and use those agents. Now, intravenous artesunate was available through an IND from the CDC till about 2 years or so ago, but the CDC no longer supplies it. It is now commercially available in the United States, and you should have it on your hospital formulary. There's a company that's actually set up in order to distribute IV artesunate or to produce and distribute it through drug distributors, and it's called Amavas. I have no association with them, but you can go to their webpage. The CDC links directly to it. You can order it. They say they can get the agent to you in 6 to 12 hours, et cetera, but we just stock it on our formulary at Mass General. We keep a couple of treatment courses because malaria is not that infrequent for us, and treating with IV artesunate is not that infrequent, so we stock it in-house. How do you decide if the person needs IV therapy as opposed to orals? And there's very specific, you can look them up, but a lot of it is common sense. Is the person unresponsive? Are they ventilated? Are they on renal failure? They have a bleeding diathesis, et cetera. So those are pretty straightforward. The two that often pull it are if parasitemia is greater than 5%. Because remember, in falciparum, what you see in the peripheral blood is just the tip of the iceberg. So someone who comes in at 6 or 7, like this person came in at 7%, actually a lot of their red blood cells is infected. It's only 7% of the circulating ones, but most of them are docked in the postcapillary venules. And that leads you to also, they're ischemic in their tissues. So if you have persistent acidosis, either with lactic acid or someone comes in with a bicarb of 14 and I throw a liter or two in them, and 6 hours later their bicarb is still 14 or 15, that person is not perfusing their tissues. And that's another indication, persistent acidosis, for pulling the lever for IV artesunate. There's no renal or hepatic adjustments. The agent is given over those 3 time courses, and then you follow the parasitemia. It's a very rapidly acting drug. So usually the parasitemia level falls very precipitously, and once they go less than 1%, then you switch them over to complete a full oral course. Obviously, if the person gets IV artesunate, you do have to follow them at least weekly for delayed hemolytic anemia, because the medicine is so good at killing the parasites, and the people who get this have high-level parasitemia usually, that a lot of the red blood cells are getting cleared over the next 2 to 4 weeks out of the body. And so if they have that hemolytic anemia, you have to follow it, and sometimes we readmit the person and give them additional units of blood if required. Once again, the CDC has a 24/7 hotline, so call if you have any questions. All right, the main one on malaria that I want you to get across is, hey, it's a bad illness. Prevent it, treat it when you see it, recognize it. Low threshold for checking malaria tests if the person comes back with fever, especially 30 to 90 days after they've come back. And your real choice is an oral ACT or IV artesunate. Make it simple, get them on formulary. All right, case 2. So I want to thank Howard Heller for pointing this case out to me. So this is a 23-year-old gentleman who had traveled for 9 months through South America, including trekking in the Tuichi jungle in Bolivia. And so for those, evidently this is a common thing for a lot of young individuals to do. Evidently there was a book written by a young man, Yossi Ginsberg, who traveled through the jungles in Tuichi. Tuichi is down, if you see where the X is on the map on the lower left-hand side, it's up in the, it's in a national park area on the border sort of between Bolivia and Peru. And this book is about how he sort of survived and made it through this very dangerous area with regard to, the jungle, etc. And it was actually eventually made into a movie starring Harry Potter, Daniel Radcliffe. I had never seen the movie, never read the book, but people go to this destination because of these background. All right, so soon after trekking, he comes back. He develops a small papule in his left forearm. You'll see a photo in a second, and it continued to expand and eventually ulcerate, and that's what he came in with. He'd had it for about 3 to 4 months at this point. People usually come in. It takes them a while because they think, oh, it's just some sort of ditzel or something, but it's painless. They're asymptomatic, etc. And so usually, and especially if it's in a part of the body they don't see every single time they take a shower or something, they come in. I'm always amazed that it usually takes them a couple of weeks or even months to come in. So hopefully you recognize this could be a cutaneous fungal infection. It could be something else, mycosis fungoides, etc. But with this background, what else do you think it might be? So what is this? And hopefully you're yelling out, I think this might be cutaneous leishmaniasis. And obviously this is acquired in the New World. So it would be New World cutaneous leishmaniasis if that's what it is. And he rolls up his shirt for you. And he says, oh, doc, I also have this. And he rolls up your shirt. And he has what looks to be sort of an angry sort of lymph node up higher. So what is that? So that's lymphocutaneous spread. So lymphocutaneous spread is also called sporotrichoid spread. And obviously the causes, sporotrichosis, which is a fungal infection, classically does that. Nocardia can do it. Mycobacterium marum can do it. And then very specific subgroups of the cutaneous leishmaniasis, including the New World Braziliensis complex, although some of the other ones can do it as well. So this is screaming out at you that this is a New World Braziliensis complex. So how do you diagnose? Okay, so you think, I know what this is. How do you diagnose it? You can just do clinical recognition, but if you wanted to diagnose it more specifically, usually it comes down to biopsy or aspirate. You don't check serology or anything like that. It's a biopsy or an aspirate. I tend to be a margin biopsy person. I don't particularly, the aspirates don't do much for me. Some people like to clean off the ulcer and biopsy or aspirate at the base of the ulcer. I tend to do the margin. And I usually send a little piece for path. I send some for PCR and some for culture, and the CDC will do those latter two. I'll show you where you can send these things. Now, sometimes, obviously, unless you know the person's coming with cutaneous leash, you might not have the appropriate stuff in your office, but actually you do. Meaning you just have to drop this in physiological saline, sterile, normal saline that's sterile, or PBS. If you have a viral lab, you can test in viral culture medium. It doesn't have to be anything fancy, just some sterile normal saline. It can be dropped in that, put into a little tube, for like you check your UAs and et cetera, and you can send that off to the lab for them to send down for PCR and culture. There are a couple of places around the world that can help with diagnosis. You see the CDC list in the middle, also in Montreal, and Walter Reed can also assist as well. Now, I'll come back to this resource, leishmaniasis. Through IDSA and ASTMH, we put together guidelines both for diagnosis and treatment, and that's a wonderful resource. And so I'll refer to it a couple of times. It's available free on the web. Just go to the IDSA or the ASTMH websites for the guidelines. So this one was sent off for PCR and was positive for Leishmania viana guianensis. And so this is a Braziliensis complex. So when you look at Leishmania, patients can be categorized in those with cutaneous disease, and we break it down into either Old World or New World, or it involves the mucous linings of the face, and we call that mucocutaneous disease. It's usually the Braziliensis complex, or it's deep in the body without skin lesions, and we call that visceral leishmaniasis. And there's a smaller type that we call viscerotropic. Those are ones that don't usually go deep that sometimes can. For the Old World cutaneous, those don't, after the Old World lesion heals, they don't usually cause you any problems. But the New World, if it's a Mexicana complex, it doesn't cause you a long-term problem. But the Braziliensis complex can reactivate in the nose or the mouth, and we call that mucocutaneous spread. So that's what we're trying to figure out if the person's at risk for, because we don't want the destructive lesion in the central part of the face. So what do you want to do next? So the PCR is positive. You were right with the diagnosis. You think it's Leishmania guianensis. You want to make sure, well, that's a Braziliensis complex. I want to make sure, is there any mucocutaneous involvement now? And or is this person immunocompromised? And then I'm going to stratify or stage which type of leishmania there are. So how do you stage and how do you treat this? And once again, I take us back to those guidelines that we put out on the diagnosis and treatment. So here's the distribution of the map that's in there. It's a very nice resource with regard to where is cutaneous leishmaniasis and which species are involved, et cetera. And so this person, if you remember, was down at the border between Bolivia and Peru. And so that's an area of the world endemic for Braziliensis complex, including what we call the mucocutaneous belt. And so you can sort of say, well, do I need to treat a person or not? And basically, if they have what we call complex disease, they're immunocompromised, they have a type of leishmania that can cause mucocutaneous disease, they have a lot of lymphadenopathy, they have multiple lesions, they have large lesions, the lesions continue to enlarge, sort of the common sense things. We usually call that complex cutaneous leishmaniasis, and we would usually recommend treating. And this is what we're trying to prevent in the Braziliensis. This individual had chronic mucocutaneous disease that destroyed the central part of the face. This is not a visceral leishmaniasis case, but I'll just show it to you because I'm not sure how many talks you'll ever get on leishmaniasis. But there's a really nice map in there, and about 90% of leishmania in the world is reported from 5 countries: sort of India, Bangladesh, Brazil, East Africa, etc. All right, so let's go back to he's a complex New World cutaneous leishmaniasis from the mucosal belt. So what do you want to do? Well, actually, you really have just a couple of agents that are readily usable. In the United States, we have oral miltefosine, which is FDA approved, and we have for leishmaniasis, and we have IV liposomal amphotericin, which is also FDA approved in the United States. So usually we treat individuals. So this person would warrant treatment. And usually, just because of convenience, we usually go with the oral agent first. And the person took their oral miltefosine, but there was no improvement, which is not that uncommon, to be honest with you. So what do you want to do next? The next couple of slides are just to show you how complicated this field is and that there's really no right way, per se. We ended up listing by type of leishmania agents sort of in alphabetical order more than anything else, because very few of them have been studied in head-to-head comparisons, etc. So here's a listing for treatment of leishmania available in the United States. Parenteral is listed there in the middle part. Oral starts on the bottom. Then it continues. There's intralesional approaches. There's topical approaches for cutaneous. There's heat therapy and cryotherapy. And then you move down to alternative agents, and then you move into the this is the mucosal leishmaniasis, and you see there's a couple of agents that can be involved, once again in alphabetical order. And there's a visceral on the bottom. Let me go back there, start getting you confused. But the visceral is actually simplest. It's like visceral. Oh, if they have visceral, let's give them liposomal amphotericin in the United States. Most people, there are other agents you can use, but like pentavalent antimonies. But that's what most people would use in the United States. So we went to the next agent here, which is IV liposomal amphotericin, and the individual did improve. They get a daily dose there's a couple of ways you could do it, but usually it's a daily dose for 7 days. So it requires a PICC line, etc. That's why we usually start with oral. But however, even though there was some initial improvement, 2 months later, it started to grow again and lymphadenopathy increased. And these are pretty common with these Braziliensis. It's a hard parasite to treat. So at this point, you have a couple of options, right? You can go to one of those, you can go to pentamidine, and you're not aficionados, but it does have special efficacy for the Guianensis complex. You can go with a longer course of IV amphotericin, but the pentamidine has lots of side effects. You can do combination therapy, or you could use antimony, the old pentavalents. You have to get those from the CDC, and you wouldn't know this unless you're an expert, but like the Bolivian strain tends to be relatively resistant to those. So at the end of the day, a longer course of liposomal amphotericin was sort of the least resistant course, and he slowly improved on this, and he gets follow-ups routinely for at least a year or two, if not longer, for ENT, looking for any mucocutaneous recurrence. All right, that was case 2. Let's go on to case 3. 69-year-old gentleman with a couple of comorbidities, some diabetes, hypertension, some coronary artery disease, and he comes into your emergency room with some epigastric chest pain. So you think, oh, this is the right, substrate for coronary artery disease. So he gets admitted. He gets a rule out MI. After some probing, it looks like maybe it's not really, it's an atypical sort of upper body discomfort, etc. So he gets an EGD. There's no gastritis, etc. But people note that there's some mildly abnormal liver function tests, and someone gets an ultrasound that then goes on to a CT. And what you see here is this large lesion in the liver with what looks like an internal structure of some sort. So some background, this individual is now 69, but they were born in Afghanistan and they came to the United States about 20 or 30 years ago. The person otherwise is pretty asymptomatic, no fevers, no eosinophilia on peripheral blood, no shortness of breath, wheezing, urticaria, etc. So what is this? What do you want to do? How do you want to approach it? And what do you want to send? So hopefully you're saying, Afghanistan, liver lesion, especially with internal structures. I think this might be Hydatid disease or cystic echinococcosis. And so that would be the leading diagnosis. You know, an amoebic liver abscess tends to be more symptomatic. It wouldn't really have those internal structures. A pyogenic liver abscess tends to be more symptomatic, usually has biliary abnormalities, and it usually doesn't also have that internal structure that looks like it's pulled away from the wall, although you can get septate in those. So what is echinococcosis? It comes in a couple of different flavors. Cystic echinococcosis, or hydatid disease, is the dog tapeworm. And so we get it. The normal life cycle is the dog poops out these little eggs, etc., and some ungulate, a sheep, a camel, a yak, etc., depending on where you are in the world, will eat those. And then the dog will eat the offal of those animals, or bring them down. Wild dogs will bring them down and eat them, etc. And that's the normal life cycle. And when they eat the liver, which has a cyst, say, of the sheep or the yak or something, then the little parasite comes out and forms a tapeworm inside the dog's small intestine. We unfortunately can just be like the sheep or the camel, etc., and we can eat some of these eggs if our meals or our hands get contaminated with dog feces, and those little eggs come out, and the oncosphere will come out, and it can go to all different spots in the body. The leading spot, obviously, since it's coming from the intestine, would be that it sets up shop in the liver. So diagnosis tends to be one of clinical recognition, and especially radiographic appearance. We often get a serology test, and then obviously pathological diagnosis is the gold standard. So here are some people with hydatid disease, and what you see is those brood capsules or daughter cysts will often form inside. Not always, but they're often present, and other things don't give that. So when you see those, they're almost pathognomonic for cystic echinococcal disease. And you can see there's different layers of the parasite, and it can pull away from the wall. In this individual, this is one that would be dying or dead because it's pulled away from the wall, etc. If the parasite dies, it can sometimes solidify into a jelly-like thing. I'll show you in a second. But sometimes it just becomes like a liquid ball, and the debris, we call it hydatid sand, can float to the bottom. And in this one, you see that sort of clump of sand on the bottom. If you were to roll this person on their side and check another CT, this would move to the bottom of wherever it is. It's a dependent sand. So either sand or a jelly-like thing is usually what they look like when they're dead, with or without calcifications. So how do you approach them now that you think you know what this is? First of all, I'm always struck with how remarkably asymptomatic these individuals are. They'll often come in with a softball or a basketball somewhere in their body, and it's been growing for decades. You often, depending on the location, but a liver one tends to grow about 1 centimeter a year. So if you have somebody with a 30-centimeter process, that's been going on for a couple of decades. So it's usually not an emergency. You really, and what you want to do is you want to sort of stage the person or characterize their status. And that depends on the location, the complexity of the cyst, their size. If there are any complications, is it leaking? Is it right at a border where it's going to leak? Is it attached to the biliary system and they're getting biliary involvement, et cetera? If it is in the liver, we usually do an ERCP or an MRCP because we want to figure out if there's biliary involvement, because that'll change what you might want to do. You can look at a CBC. If it hasn't leaked, they won't have eosinophils. But if you see eosinophils, that suggests it's leaking somewhere, and that kicks the ante up a little for what you want to do, because those are the people who can anaphylax once they've been sensitized, and it suggests that there is leakage going on. So you probably have to do something mechanical. And I talked about the MRCP or ERCP. So what are your treatment options? So some people you can follow, some people you can give pills, some people you can approach sort of radiographically with what we call PAIR, which is percutaneous aspiration, instillation, and reaspiration. Some people will combo that with medical. Some people will take to surgery, and some people will combo surgery with medical. And so how do you figure out which one you want to do? So once again, have a low threshold for calling in people who have experience with this parasite. And I don't want to confuse you too much, but you should have to stage which stage you think the person is in. If you look at the photos on the right-hand side, go to the middle panel. Those are sort of the simplest. If you have a simple cyst that looks to be viable, we call that a stage CE1, or cystic echinococcosis stage 1. And depending on its size, we classify that into a small, a bigger or smaller one. And you'll then look at the table on the left-hand side, and you'll see that you could, if it's a small one and it's a simple cyst, you could try albendazole or you could try PAIR. If it's bigger, you probably have to bring PAIR into the picture. And then you work your way down. You can get into a CE2, which is a multiseptatus. You have daughter cysts, etc. And usually in those situations, we'll do some sort of mechanical procedure as well. Then you move into what we call transitional cysts, and that would be the 3A and 3B. And those are, if you notice, if you look at those cysts, the mother cyst is sort of lighter appearance. That's a jelly-like material because the mother has died, but the daughter cysts are still viable, and that's why they look hypodense on that image that you see. And so these transitional things, if it's a late transitional, you could just follow, et cetera. But if you think there's any viable component, usually we'll do something mechanical, either pair or surgery. And then the later ones we call the inactive lesions, and those will be where we think everything is dead with or without calcifications. And in those, you don't have to do anything, because you're not going to change anything. It's basically just a big scar or tissue type thing there. All right, so for this individual, and what do you do if you do medical? The mainstay is albendazole. Some people, there's not a consensus on this, but some people give praziquantel around the time of surgery. And usually if you start this, we just start albendazole. If you're going to take them to something mechanical, we usually start albendazole maybe 10 or 14 days before, and we don't want too much albendazole on board, because if the albendazole has really killed the thing, not really killed it, but made it soft and squishy, it's a lot harder to deal with in a mechanical level. And so we sort of do 10 to 14 days, and then we'll go, depending on how complicated the mechanical procedure is, was there spillage or not, did they get it all or not, and then we'll make a decision at that point, anything from a few days post-op to a few months post-op. And so really, it just comes with clinical experience to know what might be the best for that person. So for this individual, they got albendazole based on its appearance and everything and its size. It was decided to take this person to the operating room. Oh, here, this slide just tells you what you can do. This individual got the agents, and they went to the OR, and they had a hepatic cyst fenestration. You don't have to take the cyst out. Usually the surgeons will just open it, either through a window called a fenestration, or they'll also do a marsupialization, where they'll open up more, and then often do an augmental flap in there because of the large defect, etc. So the cyst fluid was sent off, and what you see is the protoscolices of the parasite, or some of the hooklets on that inset up there that you see. The pathological diagnosis was consistent with cystic echinococcosis. And so how do you then follow these individuals once you've decided how you're going to treat them and you do that? And it really depends. If you think you cured, right, so that's great. I usually check an image, either a CT or an MRI, a few months afterwards, just to get their new baseline. Usually there's a large defect in the liver at this point, or they've had their pair, et cetera. So you just want to see what their new baseline is. And then there's no magic rule, but usually we check at least every 12 months for 1 to 2 years, just to see if anything spread, is anything growing, is the process improving, or is the process enlarging, et cetera. And then when you sort of convince yourself that, we followed for a while, there's no change, it looks like we cured this individual, et cetera, then you can usually stop those imagings at that point. There's really no role for serology following. You have to be very careful which assays you're using, and they're not necessarily standardized or quantified, et cetera. And what you're looking for is metastatic seeding or recurrence or enlargement, or any complications secondary to the intervention that you did. Everything we just spoke about is sort of how to approach an individual with the most common area, which is the liver, but you'll also see individuals with extrahepatic. And the take-home message is, if you see anybody with it in the lungs, the bones, the spleen, et cetera, you have to approach those surgically. Don't do them medically alone, and don't do them pair alone. You just run into too many complications. So you really should approach these surgically. Here you see a woman who came in with what looks like a very high, she was a little short of breath during pregnancy. And so she eventually had a chest X-ray, and she had a big process. It was actually subdiaphragmatic. It was actually in the lung. So it was super diaphragmatic, and was a big echinococcal cyst, originally from Kenya. Here's somebody who has a couple of retroperitoneal cysts, et cetera. You have to take these people to the OR. Don't do pair, and don't do medical management alone. All right, 2 more cases. We'll go to case 3. This is a 35-year-old female who's brought in by her family after a new onset seizure in the house, which looks to be a grand mal or tonic seizure. She's brought into the emergency room. She's afebrile. She's postictal, but there's no focal findings. As she wakes up, you find no focal findings. Her fundoscopic exam is okay, so you don't think there's an amazingly high intracranial pressure. And you get an imaging, and the imaging shows a ring-enhancing lesion of the brain, single with surrounding edema. So this might be a pyogenic brain abscess. This might be something else. This might be CNS lymphoma. If she's immunocompromised, this could be toxoplasmosis, et cetera. So, but with the epi that I just gave you, a young woman from Latin America, et cetera, no other past medical history, not known to be immunocompromised, et cetera. Hopefully you're saying, oh, I think I know what this is. I should say she immigrated, maybe I didn't tell you this, story. She immigrated from El Salvador about 10 years previously, and negative past medical history. So hopefully you're saying, oh, I know what this one is, and you suspect this is neurocysticercosis. So how do you address this? How do you diagnose it? So first of all, this is not a medical emergency. Echinococcosis is not a medical emergency. Malaria is a medical emergency. Cutaneous leishmaniasis is not a medical emergency. So you don't have to figure everything out in the first 5 minutes. So usually in the situation, we check a serology. For a single lesion of the brain, serology is reasonable, but not great. If it comes back negative, you haven't really ruled out the diagnosis. If it's positive, it's very consistent with the diagnosis. And usually that was a CT. We'd go on and get an MRI, and we're looking for sort of pathognomonic features, et cetera. You can check whether the person has a concomitant tapeworm, but that's not too common, maybe only in 20% of people. So if you find it, that's good circumstantial evidence. But at the end of the day, this tends to be one of clinical recognition. Obviously, you would check an HIV, et cetera, to establish whether she's immunocompromised. So this one, as opposed to the dog tapeworm, this is what we call the pig tapeworm, which is sort of a misnomer, because actually we have the tapeworm. And so we have the tapeworm, and we pass out the eggs, and the eggs go into the tissues of the pigs, and we eat the pig tissue, measly meat, and we get the tapeworm back again. But just like the pigs can get the little oncospheres growing in their body and their muscle fibers, we actually can be an intermediate host as well. So that means we actually, if somebody with a tapeworm preps a meal for us, or we can infect ourselves, and we eat a meal that's contaminated with the eggs from somebody with a tapeworm, we can get those little oncospheres. Now, as opposed to the oncosphere of echinococcosis that sort of goes largely to the liver, these little oncospheres like to go to muscle largely. So they go all throughout the body, and these muscles get to be pea-sized, maybe a grape size, et cetera. They grow for 5 or 10 years. They're really asymptomatic largely. They produce a whole bunch of local immune modulators, so they're immunologically silent. And then what happens after 5 or 10 years or so, the parasite dies. All right, it wanted to get eaten by another human being, effectively, right? And so that doesn't really happen. And so these parasites eventually die. And when they die, they lose their immunological cloaking device and they become symptomatic. So if it's in your bicep, you get a little sort of bicep pain or something there. You think you pulled your muscle, but it goes away in a couple of weeks or so. In addition to muscle fibers, this parasite has a propensity to go to neurological tissue, especially the brain or the eyes, et cetera. Those are classic places where it goes to. So if you have a small, slowly growing lesion, it might be asymptomatic for many years, et cetera. But when you lose that immunological cloaking device, you suddenly get a space-occupying lesion in your brain, and it's inflammatory, so you get edema and enhancement, et cetera. And that's what this woman came in with. Her parasite, she'd been in the country for about 10 years, and the parasite that she probably picked up in Central America was now causing her a problem. Now, how do you approach, diagnose, and treat these individuals? Just like we did the guidelines that we did for leishmaniasis, we did guidelines also for cysticercosis. And so these are in, once again, they're free on the IDSA and the ASTMH websites for under guidelines. And you can sort of, we have to, once again, you have to stratify or characterize what type of neurocysticercosis the person has. Is it in the brain tissue itself, or is it outside, sort of extraparenchymal? Meaning, is it in a ventricle? Is it a subarachnoid? Is it in the spine? Is it in the eye? And once you've established that, you sort of have to then say, how many do they have? And do I think this thing is viable? Is it living? Is it dying? Or is it dead? And once you stratify all those different things, then you come up with which of these 3 main categories you may want to do. If you had only calcified granulomas in your brain from old dead cysts, you don't have to do anything, right? Maybe if the person's having a seizure from a focus or something, you put them on some anti-seizure medicine, but you don't have to do anything about the parasite because the parasite's dead. All right. Now, if you think the person has living parasites, et cetera, you sort of have 3 tools. There's an antiparasitic agent, usually albendazole or albendazole with praziquantel. Do I want to give an anti-inflammatory agent like a steroid? And we usually do. If we give an antiparasitic agent, we almost always, or you should give a steroid or an anti-inflammatory drug. And the reason for that is that as you're killing these parasites, you're worsening inflammation. And this is a closed space in the brain. And then we don't treat everybody with anti-epileptics or anti-seizure medicines unless they have a seizure. So if you just came in with a space-occupying lesion, bad headache, but you're not having seizures, I don't put you on a seizure medicine. I might tell you not to drive or something like that, just until we get this thing under control. But but we usually only put seizure medicine on people who present with seizures or have seizures. All right, and then you break it down. If you look at the viable parenchymal, which is what she'd be in the category of a dying or a viable parenchymal, if you have more than 2 lesions, we usually give 2 drugs, albendazole and praziquantel. We do that for 10 days. If you have 1 or 2 lesions, we usually give just 1 drug, albendazole. And we'd give the steroids, and in this one, when she presented with the fever, we'd give an anti-seizure medicine. People always say, well, what's the dose of steroids? And the answer is nobody really knows. We give, usually I do 40, 40, 40, 20, 30, 30, 30, 20, 20, 20, 10, 10, 10, off, off, off. But there's no magic. My logic is I go for at least the 10 days because that's where the parasite is getting killed with the medicine, and inflammation will lag that by a day or 2 at least. So I usually give about a 14-day course. If you only have calcified on the top there, what you notice is we don't give antiparasitic agents. And there's a couple of other categories: cystic circle encephalitis, intraventricular, subarachnoid. These can be harder to treat. And so, sometimes you have to do endoscopic marsupialization if it's in a ventricle. Sometimes you have to shunt the individual if it's subarachnoid or they're blocking CSF flow. If it's ocular, usually you have to do a laser or a heat in order for the back of the eye with steroids. These can get complicated, so you want to call in experts. All right, here's some pathognomonic imaging. So if you look at the middle one, you see the head of the tapeworm is inside. Those would be pathognomonic. You can see the one on the right in the brainstem one, that's pathognomonic. These can be hard to treat, right? If you kill that parasite right at the brainstem, that person's going to have problems, but that parasite's going to die anyway. So you want to do it in a controlled situation with steroids and under observation, et cetera. And you see one on the below right-hand side, a 4th ventricular cyst with hydrocephaly because of blockage, et cetera. And here's somebody who had multiple cysts in their brain at the time of autopsy. Once you treat the individual, usually we get we re-image, usually with an MRI as opposed to CT, but sometimes we get both, depending on what we're looking for. And we'll do that for every 6 months until we think that that we've cured the person. Doesn't mean that the lesion will totally go away, but it shouldn't be growing or anything like that. I personally don't follow serologies. I don't think they're particularly helpful. All right. And then case number 5, which is our last case. So you're consulted in the ICU on a gentleman who's intubated, and you're consulted because it looks like a run-of-the-mill sort of ID case of a critically ill individual with E. coli in the blood. But also there's another bottle, which is an enterococcus, and another bottle is growing an anaerobic gram-negative rod to be identified. So this sort of smells, polymicrobial bacteremia. I think the person might have had intestinal perforation. So you look at their images, et cetera, but there's no free air. You look at the individual, they're in multi-organ failure. So what do you want to do? So the first thing you want to do is put gloves on, if not already, because this person probably has disseminated hyperinfectious strongyloidiasis. So what is this? These are parasites or worms of us, and they usually go from person to person. But although you can auto-infect yourself. They can go through an intermediate dog host, which can also serve as a definitive host, and the worms can also go into the environment, and then you can actually get infected either from the environment, from an animal, or from yourself, et cetera. And what usually happens is once you get infected, so you grew up in somewhere of the world where you have strongyloides in your intestine, et cetera, and you can auto-infect yourself. So as the parasite passes in your stool, if you get it on your hands, or it actually goes through your skin. So if you have it on your hands and put on another part of your body, the baby parasite can go through your skin. If you don't clean yourself well in your perirectal area, it can go through your skin, and you can have this auto-infect yourself for decades and decades and decades. Most people have no clinical symptoms when they have that. If you check them, it's one of the common causes of eosinophilia. But what we worry about is and this is someone who is urticaria, or we call larva recurrens, which is a rapidly moving urticarial process in the groin. These are all good clinical clues that the person has chronic intestinal strongyloidiasis. If the person gets steroids for some reason, then you lose control of that chronic intestinal phase. Well, number one, steroids wipe out your eosinophils, and they're classic for holding the parasite in check. And number 2, the steroids can also cause the parasite to mature from a non-infectious rubidiform larvae form to a filariform infectious form. And so when they can go directly through your intestinal wall then, and they take stool with them. And that's why the patients will usually present with polymicrobial bacteremia, et cetera. This individual turned out not to have recently been started on steroids, but this person actually had an ACTH secreting small cell carcinoma of the lung that made them Cushingoid. And so they had an auto-induction of steroids that led, and the person was originally from the Dominican Republic, but hadn't been back there for 30 years. So the diagnosis, usually you can just look for the parasite. You can do serology to see what their status is, but that doesn't tell you if it's active or not. I have a really low threshold just for treating for this, since it can kill, especially if the person's going to end up on steroids soon. In this individual, there was some BAL fluid, and you can see the worms swimming around. If the person is uncomplicated intestinal disease, we usually treat with ivermectin. There's no optimal. Some people treat once, some people treat twice, some people treat twice and repeat in 2 weeks. The data are all over the place. If it's high stakes, I usually give them 1 or 2 days worth. And if they're hyper, and that's immunocompetent, if they're hyper infectious, they've lost their eosinophilia, and this is a very high mortality, 50 to 80%. And so you'll try, most of these individuals are unable to take orals, but you'll do your best to get it down through an NG tube or something, but they usually have an ileus. You can do parectal, although there's variable absorption. You can get from the local veterinary hospitals, believe it or not. People will sometimes get an IND and use the veterinary preparations for subcutaneous, etc. And if the person's particularly severe or hard to clear, you can check for concomitant HTLV because there's usually an overlap. If you do treat somebody with intestinal disease, I usually don't do any follow-up. Some people will recheck an O&P or a PCR, or some people will look to see serologies, but that's not standardized. I personally don't even recheck an eosinophilia if that's what the clue was, and I certainly wouldn't do it for at least 6 months because eosinophilia usually worsens before it gets better. And after 6 months or so, if you wanted to treat it, or if you wanted to check it at 6 or 12 months and it's gone away, you feel great. If not, you might have to look for another cause of their eosinophilia. So it said, hopefully those cases were helpful for how to at least approach some of these cases that can sometimes be quite challenging. Thank you for your time, and I hope everyone stays well.